This is the next part of the high-risk newborn. So when we're still discussing the preterm baby, so when you're looking at the preterm baby, they can have significant thermoregulation issues. They have an open posture. They have a small amount of subcutaneous fat and tissue, little or no brown fat, a small muscle mass, and the inability to shiver, and poor glycogen stores, which all really increase the baby's risk of developing cold stress. And they can develop cold stress very quickly. So when you look at that, along with their thin, fragile skin, the lack of the adipose tissue, the increase in body surface area upon exposure, we really need to have a protective approach to trying to prevent a preterm baby from developing cold stress. Some symptoms of inadequate thermoregulation, we've covered these already in the normal newborn, but they come back again, and here they are, some symptoms that the baby is having difficulty holding their body temperature. These are interventions that are specific to the NICU environment. I remember when I first started being involved in the care of preterm babies, and I was being oriented, and the nurse that I was working with brought saran wrap. I thought, what are we doing? Because I've never seen saran wrap in the care of a newborn at all. But with a preterm baby, the risk of cold stress is really significant. So what you may see, one of the interventions they may implement is they will wrap the baby in a plastic sack. Some places use it's a pre-designed hospital sack for preterm babies, or some places use bubble wrap or saran wrap, whatever they use. You're going to use it, and you're going to wrap the baby with that and with warm blankets and put them in an isolette to transfer them to the NICU environment. That's how fast they can start to develop cold stress. So we're going to have immediate interventions to address their the risk of cold stress, because we do not want them to develop that. We are going to try to implement a thermal neutral environment. We want a warmed ISOLETTE. Older term for that is incubator, or a warmed radiant warmer. We want warmed surfaces, so putting them down on warm blankets. They're going to administer warmed humidified oxygen, warm humidity. They're going to warm their feedings, and we're going to try to keep their skin warm and dry and their head covered. I've already showed you an isolette. We talked about this in the normal newborn. It's big, but some babies cannot be in an open crib environment because of their thermoregulatory needs, so they'll be taken care of in an isolette. Older name for this is an incubator. And we may have to do our initial interventions for this baby under the radiant warmer or the open warmer. When you're working with a baby that has to be in a neutral thermal environment, you want to prevent the need for increased O2 by maintaining their temperature, keeping the portholes to the isolette closed. Think of like that as putting the baby next to an open window with cold air, because that's essentially what it does. We're going to wean them to an open crib. They're going to wean them out of the isolette to be able to maintain their own body heat and temperature to an open crib. We're going to wean them to a shirt and a diaper, and we're going to watch them closely for several days after we initially transfer them. We talked about the need for the neutral thermal environment in the normal newborn baby, but in the preterm baby, it's crucially important, because we don't want to increase the need of O2, the O2 demand on their body and their metabolic need. We don't want them to become acidotic. So you want to maintain that neutral thermal environment and frequently assess their temperature. Less mature infants lose more heat and produce less heat, and they need more warmth to maintain their heat. So they need a lot more thermoregulation to be able to maintain a neutral environment. And through this gradual process of weaning, we will wean them from the isolette to the open crib. The next high-risk component that we're going to talk about, and it's still an issue with preterm babies, we're still under that umbrella, but that is dealing with the baby's fluid and electrolyte balance. You learned already in the pediatric content how to weigh their diapers. We will do that in this environment, but we're going to do some other specific environments. they have a fragile balance between too much and too little fluid. It's a kind of a tightrope that you'll find yourself walking. So we're going to do daily weights. We're going to do strict eyes and O's on them, and we're going to monitor their eyes and O's. We're going to do accurate IV rates. They're going to monitor their IV site every hour. We're going to do accurate oral feedings, whether they're doing an oral feeding or gavage feeding, and we're going to monitor their urine pH and specific gravity. We're going to give the IV fluids as prepared. We try to dilute them as little as possible, and most pharmacies send up meds ready to administer. There are a few occasions where you might have to, but you're going to want to follow your instructions specifically on that. You're going to frequently monitor your IV sites and prevent infiltration, and we're going to always give them their IV medications on a pump. An older child or an adult can handle an infiltration, but that can be a significant issue for a preterm baby. Excuse my cough. So when we weigh them, we do it the same time, every day with the same scale. Frequently monitor the babies for signs of overhydration or dehydration. And again, always keep their meds on a pump, their IV meds on a pump. Some babies have to have their IV meds delivered to them through the umbilical catheter, which uses the umbilical vein. This could be a good thing. Remember, we talked about the umbilical vein when we talked about their circulatory adaptation, but this requires less need for more needle sticks than we're already going to give to them. And we have this vessel, and it's plump, ready, and right there. It's just not going to be there forever. So it's a short-term intervention that's going to be used. They may have to place a PICC line or Broviac line later, but right now they can use the initial days after birth, they can use an umbilical line. When you look at the kidney development in the baby, we don't get into fetal development in a 5-week course as much as I would like to, but just keep in mind that fetal development is really not thoroughly complete in your fetus until about 35 weeks of gestation. And their ability to concentrate urine is poor. They have this fragile balance or tightrope that you're walking between dehydration and overhydration. So you want to monitor their intake and output. These are the signs of fluid imbalance in the newborn. Again, we talked about these in the normal newborn baby, but they come again in your high risk content. So they may have, when you look at their output, they don't have the ability to concentrate urine. Their weight loss may be greater than expected. They may have dry skin and dry mucous membranes, a sunken anterior fontanelle, poor tissue turgor, and when you look at their blood, their diagnostic tests, they'll have elevated sodium levels, elevated protein and hematocrit levels. And these are symptoms of overhydration. So we went from one extreme to the other. So you can have weight gain more than expected, bulging fontanelles, decreased sodium, protein, and hematocrit levels, moist breath sounds, and difficulty breathing. And this is a nurse that's providing care for a baby that is dealing with fluid volume overload. We talked briefly about Phytops hydrops fetalis when we were talking about RH differences, but this is the risk. This is a problem that can lead to, and this is what this baby has. But if you notice, this baby's extremely edematous. Walking that tightrope can be a challenge sometimes because it's a fragile balance, and they can go into overload or dehydration very quickly. Here are, just for those who are visual and need a visual picture versus words on a page, symptoms of fluid volume deficit: the sunken fontanelle, the reduced level of consciousness, the dry mucous membranes, the decreased tissue turgor, tachypnea, poor urine output, weight loss, tachycardia, hypotension. They can have peripheral vasoconstriction, reduced capillary refill time, and their eyes may appear sunken in their heads, and when they cry, it's tearless. And here's a baby that is dealing with severe fluid volume deficit. Now let's go into problems with infection. The rate of infection in the preterm infant is 3 to 10 times greater than that of a full-term baby boy. Excuse me. Let me say that again. I got ahead of myself. The rate of infection in preterm infants is 3 to 10 times greater in a full-term newborn baby. And many infants have at least one or more episodes of sepsis. What I was going to say was, and when I said the baby boy is, remember I made that comment that baby boys don't do as well with some complications than female babies. Infection is one of them, but I don't want you to focus on that. I was just going to comment that sometimes your male babies struggle a little bit more with several of these complications. But when you look at preterm babies in general, many infants have at least one or more episodes of sepsis while they're in the hospital. There are different contributing factors to this. If mom had an infection, they were exposed to infectious process in utero or during delivery, during birth. Also, preterm babies don't get that transfusion of antibodies during the last few weeks of pregnancy that the term baby gets. It happens during the 3rd trimester, so they don't get the immunoglobulins from mom. And their immune system is immature, so they have a decreased ability to fight off infections. And then, of all places, we put them they're in a hospital where you have a collection of very sick individuals with lots of bacteria and viruses in a very reachable environment to them. Their skin is also thin, fragile, and permeable and easily damaged, and we do a lot of invasive procedures in our attempts to try to stabilize and help them. So those exposure to those circumstances and situations can increase their risk of developing infection. We talked about torque infections briefly when we were talking about the high-risk mom, and I told you we would get into torque infections more in the high-risk newborn. So TORC is a acronym that stands for different conditions that can affect the baby and the high-risk environment. And T stands for toxoplasmosis. Other stands for syphilis. You have and other conditions, and you have rubella, cytomegalovirus, and herpes. Some textbooks actually, instead of using torch infections, they use storches, and which HE stands for herpes and S stands for syphilis and serum hepatitis. So let's look at each of these. Basically, when you look at all these conditions, they can be technogenic to the fetus. They can cross the placenta, and they can adversely affect the developing fetus. Each of these conditions varies depending on developmental stage that the fetus was at the time of exposure. So let's start with toxoplasmosis. It's a protozoa infection in the pregnant woman. It's found frequently in cat feces or in raw undercooked meat or in improperly washed vegetables, fruit, which is more rare than the other two. The effects on the fetus include it can cause blindness, deaf. The baby can be born deaf, convulsions. They can develop microcephaly, hydrocephaly, and severe mental impairment. And the next condition I want to talk to you about is cytomegalovirus. It's very similar to herpes, and the way herpes unfolds, it can remain dormant. It has periods of dormancy. It crosses the placental barrier, and the baby gets this condition from direct contact from mom during the birth process. So you have an increased risk of hearing, vision, neurological, and developmental problems for this baby if they develop this, as well as they can develop pneumonia. Importantly, and sadly, there is no vaccine for this condition. So some of the symptoms that you'll see in the newborn: severe neurological problems, eye abnormalities, hearing loss, microcephaly and hydrocephaly, depending on where the fetus was at the time of development when they were exposed to this, cerebral palsy, and mental delay. Babies can also be exposed to other conditions in utero at birth, and they can acquire these infections before birth or during the process, such as herpes. And this is where we're going next. This baby contracted a genital herpes infection from mom during vaginal delivery and subsequently ended up in NICU with a herpetic infection. Now,